They're always looking for where the next bathroom is. If you go with them for lunch, the first question to the waitress is, where is the toilet? Because most certainly during the meal, they might have to excuse themselves to use the bathroom. That about 1 in 10 people have the disease. So where you're seated, you can be sure at least 1 or 2 people have the disease. Hello and welcome back to Gut Talk. This is your monthly podcast that discusses common digestive issues. I'm your host, Dr. Edna Kamau. I welcome you back and kindly consider subscribing so that you don't miss our next podcast. So I want you to pause a bit and think about a few things. Maybe yourself or a family member or a friend suffers from tummy ache that is associated with infrequent bowel movements where they take very long before going to the toilet. They stay days without going to the toilet. On the contrast, we have people who also present with tummy pain and are always going to the bathroom. They're always looking for where the next bathroom is. If you go with them for lunch, the first question to the waitress is, where is the toilet? Because most certainly during the meal, they might have to excuse themselves to use the bathroom. And when they go to the toilet, sometimes they take very long because they feel like they're not finishing. These are the people that I'm hoping that I'll be talking to today, or their caregivers or their family members, so that we can be able to understand what exactly is going on with them. So the topic for today's podcast is Irritable Bowel Syndrome, better known as IBS. So April is IBS Awareness Month. It's a month where we aim to increase awareness about the disease, about the diagnosis of the condition, about how we treat, and how do we eventually make sure that people have a good quality of life. So please join me in the next 20 or so minutes as we go through a journey about this disease. So what is IBS? It's actually a condition because you cannot have a single test or a scan to make the diagnosis. It's unlike diabetes or cholesterol, where you go to the lab and you get a result that shows you have diabetes. The diagnosis is actually hinged on a constellation of symptoms. It's a syndromic diagnosis. It's a chronic condition. So like diabetes, like blood pressure, it stays with you for a lifelong. It doesn't necessarily mean that you will have the symptoms all the time. It's a very common disease. It's estimated that about 1 in 10 people have the disease. So where you're seated, be it in a matatu, you can be sure at least 1 or 2 people have the disease. So we make the diagnosis of IBS using a set criteria called the Rome criteria. So the Rome, it's a group of people who met in Rome in 1988 and have met consistently over the years, with the last version being in 2016, and came up with these symptoms that if you fulfill them, then we can make with certainty, 97% certainty, a diagnosis of irritable bowel syndrome. So it's not a diagnosis of guessing, it's not a diagnosis of exclusion, it's a firm diagnosis made on a syndromic basis. Times a day, for some people, it's even up to 2 times a week. A change in that consistency of how you go to the toilet is important for a diagnosis to be made. On one extreme, you could be either going too many times, or rather, you could be staying very long without going to the toilet. The second thing, and this is how we now classify whether you're going to have irritable bowel syndrome diarrhea or irritable bowel syndrome constipation. The second is the appearance of a stool. Is your stool going to be too runny, maybe to look like porridge or like water? Or on the extreme end, does it look like poop for our goats, what we call pellets, or a very hard stone, which is hard to evacuate? If it is hard, most of the time, at least 25% of the time, then you have irritable bowel constipation. If it's loose, most of the times, then you have irritable bowel syndrome diarrhea. And you could have a mix of both. So we classify you as irritable bowel syndrome mixed type. The final one is the association of the symptoms with the act of going to the toilet, with defecation. You either feel like you're going to get better after going to the toilet, or you get worse. For most people, they actually get a relief with going to the toilet. So if you have abdominal pain and either two of the three things I have described, then we can make a diagnosis of irritable bowel syndrome. And on the basis of that, we're able to classify people into 4 categories. Irritable bowel syndrome, constipation. Irritable bowel syndrome, diarrhea. Irritable bowel syndrome, mixed. Or irritable bowel syndrome, unclassified. These are important because the management at the end of the day depends on what is your prototype. What type of irritable bowel syndrome do you have? So you have us asking you these questions, and we'd want to know on most days, what do you suffer from? So the irritable bowel syndrome is unique in the sense that you could actually shift, that you could change from IBS constipation to IBS diarrhea as time evolves. As time goes on, your prototype could change. So how does the journey of making a diagnosis of irritable bowel syndrome begin? So when you come to me as a gastroenterologist, what am I going to do? Or if you go to the physician, by the way, this disease accounts for most of the work that we do as specialists, but also for the general physician in casualty, it's actually the commonest digestive problem that we handle. And the journey begins with a good history. So if you're coming to the doctor, it's good for you to be aware what are your main presenting symptoms. And we really want to know what are your last presenting symptoms, at least for the last 6 months, at least for a year, not maybe too far back, because we want to help you. So what are the main things that disturb you? And how long are they there? How many days? What's the impact it's having on your quality of life? Do you have to work from home because of your diarrhea? Do you probably have to avoid social gathering? Remember, we are very socialized around foods and activities, and are you fearing to go out because you might need a bathroom? So what's the main thing? But we also, more importantly, are there associated symptoms? There are people who come in and they also have a feeling of not finishing when they go to the toilet. It's important because our treatment will also be geared to helping you to address those symptoms. Do you have to put your fingers to probably remove the stool? Do you feel gassy? Do you feel bloated? Some people, gas is the main thing, that the pain they have is because they feel very bloated. Are you intolerant to certain foods? What is your main presentation? And then we go back and listen very keenly to what we call non-classical symptoms, because it's not always all tummy pains that are because of IBS. Remember, if you have your symptoms coming in after the age of 45, we are more keen to ensure that you don't have any other underlying problem. Colon cancer screening begins at 45. So if you've not done colon cancer screening at 45, we'll ask you to do one. Do you have things that are not classical? For instance, are you losing weight? Have you lost more than 10% of your weight in the last 6 months? That's not IBS. We have to be sure there's not something else. It could be a malignancy. Do you have vomiting? Are you seeing blood in the stool? Are you waking up at night to go and have diarrhea? That is not classical symptoms. If you don't have classical symptoms, or you have what we call the alarm symptoms, we have to do tests to ensure that we don't have an underlying problem. So we don't make a diagnosis of IBS without excluding other possible causes, including things like gallstones, malignancies, inflammatory bowel disease. Unique to IBS, we have a similar, people confuse it with irritable bowel syndrome or IBD, but IBD is inflammation of the colon. There's a structural problem in the colon that is actually making you get a problem. Unlike irritable bowel syndrome, which is what is referred to as a disease of the gut-brain axis, whereby you do not have any mechanical problem or organic problem that is causing you to have a problem in your symptoms. So irritable bowel syndrome is actually made after you exclude those conditions that can mimic the symptoms of IBS, especially in people who are more than 45 and in people who present with alarm symptoms. So what are the possible causes? It's very interesting that most people will have this diagnosis for a long time and they really don't understand what the cause is. Even the science world has struggled over the years to understand what are the causes. And in fact, it is classified as a disease of the gut-brain axis. These are diseases that are thought to occur because of a disruption of the communication between the gut and the brain. And because of that disruption, you end up getting digestive symptoms. The possible causes that have been found over years of research, and the most important one, has been visceral hypersensitivity. Visceral hypersensitivity refers to an increased awareness of the happenings of your digestive system. If you eat lunch now and you go to work in the afternoon, you'll be digesting your food, but still be able to concentrate and do your work. But for people who have IBS, their gut signals are constantly being sent to the brain. So they're constantly aware of what is happening in the digestive system. So they can't concentrate. You're feeling uncomfortable, even if what is happening is what is expected. There's a heightened awareness. The brain is unable to shut down those signals from the body, from the stomach. So you keep feeling uncomfortable when gas is produced. You feel like it's too much. You want to fart. You want to pass wind. Yet it is normal. That miscommunication, that heightened awareness is what is one of the causes of irritable bowel syndrome. The second one is gut movement, gut motility, where you have a disruption of the sequence and the coordination of how your gut moves. If the gut moves too fast, you eat and you run to the bathroom, undigested food. Or it's too sluggish, it's too slow, just like some of us, the way we walk a little slower. It takes too long for the colon to move. And if that happens, your stool accumulates. It's like a pipe which is packed up with stool. So your stool begin to feel gassy and bloated because there's nowhere for the gas to come out. There are people who who have irritable bowel syndrome after an infectious episode. You go for a hike or you go for a function, you get a very intense diarrhea, and your gut never ever feels like it's right again. That is called post-infectious irritable bowel syndrome. It's very common with the diarrhea type. And we think in that case is a reset of your gut bacteria. And that brings me to the fourth etiology, which is our gut microbiome. The human body is very interesting. We have about 1 kg of bacteria in our digestive system. They're very diverse and unique, different types. And we want that balance to remain the same. We get these bacteria as we grow up. You know, as you eat food from the ground as you're a child, as you breastfeed, you know, as you get infections, you accumulate good bacteria and you have a good balance of bacteria that is able to produce the good nutrients, absorb the bad ones. If that bacteria is dysregulated, it becomes abnormal for whatever reason. Maybe you're taking too much supplements. Maybe you have an underlying disease. If that happens, then you end up getting what we call dysbiosis, and this had been linked to causing irritable bowel syndrome. It's thought that it affects the neuromodulators, it increases the awareness, increases sensitivity in the gut. IBS has also been associated with stress, and you'll find that some people who present with IBS have anxious personalities. It's uniquely been associated, even with connective tissue diseases or disease of the bones like fibromyalgia. These are people who feel pain everywhere on their body. They have been linked up to have irritable bowel syndrome. And in times of stress, people who have IBS have also been found to have increased symptoms or to have an exacerbation of their irritable bowel syndrome. And one of the things that we do as we address the disease, we look for underlying stress factors that could actually be contributing to your symptoms. Those are the main things that have been linked up. And these are important for you to remember as we go on, as I discuss, because our treatment looks very unconventional sometimes because it aims to address what is known through science as a possible etiologies. So once you go to the doctor, as I say, the diagnosis will be made. It's a syndromic diagnosis, and that diagnosis will be made on the basis of the criteria, the Rome criteria. The test will only be done if it is necessary, maybe because of the age at which you're presenting or you have alarm symptoms, but a doctor can with confidence make a diagnosis of irritable bowel syndrome without having to do a lot of fancy and expensive tests. Once we do make a diagnosis of IBS, so how do we treat it? So IBS is it's a disease that we have to have tailored treatment. There is no one size fits all. There is no treatment that can be given to all patients. Your friend's treatment, your daughter's treatment is not the same as yours. And that is why it's important to establish a very good relationship with your doctor and to let your doctor understand the symptoms. A very good history as to what are your main presenting symptoms, what are your expectations, what do you really want to achieve, what are the main things that you'd want to be addressed through the management. With that, we're able to tailor a treatment plan that is appropriate for you, that allows you to have a good quality of life and to jump back into your social activities. So we are able to classify IBS based on the impact on the quality of life. If you have moderate IBS, it means you have an impact in terms of missing work, you're missing social activities, and there are people who have mild, and in those cases, most of the times, the treatment is much more gentle. So treatment of IBS is hinged on lifestyle changes. And the first thing on lifestyle is mindful living. Mindful living means that you have good quality sleep, that you're taking time to have your good breathing, that you have meditation when you need it, that you're able to manage your stress factors. Sometimes it might be just listening to another podcast that allows you to relax, good music, and good thing with apps nowadays. You can actually download very good relaxing music, meditation programs, yoga. It forms the basis of treatment. The second part of it is exercises. And exercises are unique, especially in patients with constipation, because they are able to actually improve the bowel movement. Remember, the gut moves a long pipe, winding pipe. So the more you move, the better. So you're going to get moving. Increasing your fluid intake. Avoiding stimulants, like for instance, caffeine, which for some people will trigger diarrhea. And then increasing your fiber intake. And this fiber intake is especially so the soluble fibers. So you'll find we give you some soluble fibers, and you don't want to take it all together because also fiber causes bloating. So it's divided in a course of day, and it's a little, not too much. If it's too much again, you're going to jump towards constipation, bloating. So less fiber is given, at least about 30 grams, that's about 3 times a day of soluble fiber. Then we go to diet. And there are many things about diet. And I'll do another podcast about diet and its impact on IBS. And this is important because there's a lot of science around it. And one of the places that has been done is in Canada, in Monash. And one of the diets that has been found to be effective is called a low FODMAP diet. This is not a diet where you print on a paper. It's actually hinged around foods that are low in carbohydrates. They are foods that are basically low in things which are hard to digest, which take very long to digest in the small intestine, so they draw a lot of water. And they also, because they're not digested, they go to the colon, and they are fermented by the bacteria in the colon, so they produce gas, so you get symptoms. These are foods, because of that water in the small intestine, you feel gassy. Because of the gas that is produced by the bacteria in the colon, you get flatulence. These are mainly foods that are said which are high in carbohydrate. So your wheat products, your lactose, your fructans, which are basically your onions and your garlics, your sweeteners, which are your sorbitol and your artificial sweeteners. Those are the foods that are high in FODMAP. So we aim to reduce those foods in your diet. And this kind of diet is tried out for 2 to 6 weeks. And then you reintroduce them slowly, one at a time. It's not full time. You reintroduce them. So once you eliminate them, you begin to feel better. You begin to reintroduce them. Remember, these are also foods which are also good for the gut. The same foods, despite the fact that they're hard to digest, they're also very good for the flora. So you need them. So you need to reintroduce them. So you take them back, but one at a time. And with that, you're able to know what can you be able to tolerate in moderation. And some of them, you're actually able to tolerate them in full. So the aim is to actually get you to a place where you're not fearing to eat. You're not avoiding everything. You're able to have your personal diet that is very palatable, that is adaptable, that allows you to be socially interactive, and is not very restrictive. And most people, if they're able to monitor their symptoms, sometimes with a good food diary, they can actually be able to have a good quality of life. Then there's a role of medication, and there's a broad array of medications. Again, it's dependent on the type. For people who have constipation, you want to give medicines that address the stool consistency, but also address the pain. Because remember, we said pain is a big component in irritable bowel syndrome. So we use constipation medicines that also address the pain component. So you'll find us using things we call secretagogue. These are like irrigation medication. They're like irrigants to the bowel. They draw in water. They secrete water to the colon to make the stool a bit softer so that it can be able to swim nicely to the rectum for evacuation. And when it's softer, it's actually easy for it to come out. And there are different categories. And they're usually taken over a period of time. It's important for you to realize that these don't work very fast like your usual laxatives. They take even up to 4 weeks. So give them time before they work. We also have people who have irritable bowel syndrome constipation. And in that case, diarrhea, sorry. And in that case, you want to give medicines that actually address the gut flora. And in that case, we give antibiotics that are non-absorbable. And there are different categories of antibiotics, and they can be repeated over different cycles. Then the role of visceral sensitivity, your gut feeling too much, it's too sensitive. You don't want it to feel. It's like you're touched and you want to jump. We want you to be quiet to numb that signal from the gut. That is where the role of a neuromodulator comes in. And this is very important. If you come to see a gastroenterologist, you'll find they give you a little dose of antidepressants sometimes. And it's not because you're depressed. It's because we're trying to numb that gut sensation. So we don't give you doses of depression. We give you a small dose because you're trying to reset your gut sensitivity. And these are again given for a long period of time, maybe 3 months, because remember you're working on the neuromodulator. So it's not a quick fix. And they have side effects, but the side effects wane over time. Remember, the digestive system has probably more nerves than the spine. So you'll find that these medicines are very effective. In some cases, to reduce the sensitivity, we might ask you to see a psychiatrist or a psychotherapy to address that sensitivity and if there's a stress or anxiety factor. And all these come together to ensure that you feel better. There's a role of probiotics in some people, but again, it's very dicey. It depends on whether the underlying mechanism is thought to be from dysbiosis. And the probiotics that are good is varied for different patients because the science around that is not very strong. So we don't give them for a long time. We don't give them forever. And it's those ones that have lactobacillus or Saccharomyces. And given, if you take a probiotic yourself and feel like it works, you can go on with it. But if it's not working, forget about it, because the science around that is not as strong as with the medications, the antidiarrheals, the neuromodulators. Then there are those symptoms that also require unique medications. For instance, if you have colicky or crampy abdominal pain, then you might need to take something for the spasms. And so we give you even simple medicines like Buscopan. And this can be used on a need-be basis. If your issue is bloating, we can give you something with Simethicone to remove the gas to reduce your symptoms. If you have a food intolerance, like maybe your lactose intolerance, just may mean taking less lactose. Things like cheese, which are fermented, which are better tolerated, are the ones that you might want to take. And with all this, you'll find that your quality of life improved. But maybe importantly is a role of review, because it's a unique and a disease with a lot of complex interplay in terms of the etiology. It's important that you come back for us to see you, because we'll want to know how you're doing. And when you come back, we want to know what has improved, what has not improved. It could be that you've got an 80% relief in terms of your constipation. So maybe we might just add something else or change the dose. Or maybe it is a symptom that has not gone away. So when you go back, the review is very important. Don't hope between doctors. It's a journey. And most doctors will be able to eventually be able to give you medicine that suits you. Maybe as a word of hope, irritable bowel syndrome, despite the fact that it's chronic, it does not cause increased cancers of the digestive system. In fact, patients who have IBS have been found to have the same quality of lifespan as patients who do not have it. And the patients who are able to work with a doctor and tailor their medications find that the quality of life is actually very good. So thank you very much for listening, and I hope to see you in the next podcast.